Thank you for having me. It's a pleasure to be here speaking with everyone. My name is Rahul Banerjee. I am currently an advanced fellow in transplantation and cellular therapy in myeloma at UCSF, the University of California, San Francisco. And I'll be joining the myeloma faculty at the University of Washington and Fred Hutch Cancer Center in Seattle this August. My clinical interests are in myeloma and AL amyloidosis, and my research interests are in the patient experience. So I've been my privilege to work with and learn from plenty of patients about how to just take the care that we're delivering and then doing it in a more patient-friendly, less financially toxic, less time-toxic manner, which I can talk about. And so lots to discuss here at the TANDEM meeting that happened this last weekend in Salt Lake City. So it's a question that comes up every year, and namely that question is whether CAR T therapy will overtake transplantation in multiple myeloma. I'll use those terms loosely. CAR T therapy, in my mind, could also refer to T-cell redirecting immunotherapies or adoptive immunotherapies, many words for these, but that includes both traditional autologous CAR T cells, where we take a patient's own cells, teach them to fight cancer, and put them back. The broader immunotherapy term includes allogeneic CAR T cells or allogeneic therapies, where we use someone else's cells and give them to the patient to fight myeloma. And then the broader term also includes all these other non-cellular immunotherapies, for example, bispecific antibodies. So BiTEs, as many of you may have heard, is a trademark. So we tend to say bispecific antibodies. There are trispecific antibodies out there. There are DARTs out there. Many types of molecules that are designed to just help our immune system fight myeloma better. And I think I think it was Dr. Usmani, one of the presenters today. It was Dr. Young before him at the debate today, basically discussing CAR T therapy versus transplant. Pointed out that look, in the last 50 years, CAR T therapy has only been around for 10 of them, but has been expanding and improving exponentially versus melphalan-based autologous transplantation. What all of you are quite familiar with, chemotherapy, and then the cells that were pre-collected coming back, has been pretty much the same in the last 50 years. We've gotten better at controlling nausea. We've gotten better at controlling some of the infectious side effects, but the chemo has not changed. So when you're comparing something that's been quite stagnant with CAR T therapy that's on the rise, is there a point in time where I can say CAR T therapy is better than transplant? Today, I think this year's iteration of the debate was quite interesting because, as all of you may know, we now have two CAR T therapies approved for multiple myeloma, including most recently siltacabtagene autoleucel, cilta-cel, Carvykti. Um, the central premise of the debate is, I think, the same. Is that there, on the one hand, you can talk about efficacy and safety, which is traditionally how we compare therapies. On the other hand, especially my generation of physicians, we like to look at the patient-reported outcomes, the patient experience, and also access to care and global equity. So I think in terms of the safety versus efficacy angle, the advantage CAR T versus transplant is still somewhat unknown. They have not been compared head to head. The upcoming CARTITUDE-6 study that Dr. Usmani briefly talked about is actually going to compare Carvykti, cilta-cel CAR T versus transplant head to head. That will give us some good answers a decade from now. What do we do now? Some of the CAR T therapies have really good efficacy results that probably, in my mind, are going to be better than transplantation. We just don't know yet. With regards to safety, it's hard to say. I think everyone knows the side effects of chemotherapy in terms of the hair loss, in terms of lack of appetite, the mucositis or mouth pain. CAR T therapy has a different set of side effects. I think the one that we're really learning more about because of COVID is the impact on the immune system. It's somewhat ironic with CAR T therapy that your immune system is both stronger against myeloma, but somehow weaker in general. The example I give with COVID vaccines are patients who undergo a melphalan auto transplant. Within 6 months, they're ready to get their childhood vaccines again. Some of them may actually still have their responses to childhood vaccines, and we just give them more vaccines just in case, give them the COVID vaccine booster, and that works fine for them. For our patients who've gotten CAR T therapy, we don't know. Some of them, months out, even years out, probably do have depressed immune function and might not respond that well to vaccines, maybe immunocompromised. We don't know yet. So I think the jury's still out about safety versus efficacy. For PRO, for patient-reported outcomes, I think the advantage definitely goes to CAR T therapy, and I did actually ask this to the presenters afterward, in terms of CAR T therapy being truly a one and done. As of right now, when someone gets a CAR T therapy, they will get supportive care, antimicrobial antibiotics afterwards, but there's no role for lenalidomide or Revlimid maintenance after CAR T therapy that we know of now. Versus for transplant, part of the transplant package is afterwards all patients get Revlimid or lenalidomide maintenance. Some get other drugs like bortezomib or Velcade for maintenance. Some get both, and so forth. And I think to that end, I think the advantage for the patient experience probably goes to CAR T therapy. And some studies of patient-reported outcomes during the process. One, there was a Dr. Sidana from Stanford presented this abstract at the 2020 ASH meeting that patients had fewer side effects as they actively underwent CAR T therapy versus actively undergoing melphalan auto transplant. And the last factor, so I talked about safety versus efficacy, just talked about the patient experience, and then equity. And I think that came up in both the myeloma and lymphoma debates is that, look, CAR T therapy is not available for everybody. Even the United States is only available to, fourth line of therapy or 4 prior lines or more. It's very difficult to get to. Insurance companies often throw up roadblocks versus auto transplant. Melphalan is the cheapest medication we have. Still, obviously, a lot of barriers to getting a melphalan auto transplant, but not nearly as many, both in the US and globally, as exist to CAR T therapy. So kind of a long-winded answer. You can tell that if I had a clear answer to whether CAR T therapy has overtaken auto transplant, I would tell you. I don't think we're there yet. Again, I think the highlights is that the patient experience almost certainly is better with CAR T therapy. The efficacy likely will be better. We just don't know yet. But there are studies that are enrolling that hopefully 5-10 years from now will tell us in the second line of therapy or in the first line of therapy after getting people's first line of therapy, is it better to go on to CAR T therapy or is it better to go to melphalan auto transplant? We'll find out. So, on the terms of what else exciting happened for patients with myeloma at this meeting, a lot of cool posters, a lot of cool oral presentations happened in terms of innovative ways, again, to both improve how we deliver care against the myeloma, but more importantly, how we deliver care to our patients. I will briefly talk about 2 oral abstracts that were presented on Sunday about ciltacabtagene autoleucel, so cilta-cel or Carvykti from the CARTITUDE-2 study. So remember that currently CAR T therapy is approved for patients who've had 4 or more prior lines of therapy. The CARTITUDE-2 study is looking at different groups of patients and giving it kind of in the second line. So either patients who have had 1 to 3 prior lines of therapy, that's cohort A, or patients who have relapsed or had progressive disease after transplant or after their first line of therapy, that's cohort B. And both of those preliminary results were presented today. They're single arm studies, so they don't answer my question that we alluded to earlier of CAR T therapy versus transplant, but I think it's important to show that the patients who got CAR T therapy did really well. Very, very encouraging overall response rates. In my mind, it's very easy to get, not easy, it's easier to get a response, in terms of just getting the M spike to go down in our patients. But I'm most interested in the duration of response. How long do the responses last for? And in both studies, the median progression-free survival, so how long were patients able to just cruise after CAR T therapy without requiring any more therapies, has not yet been reached. So over half of patients are going at least several months, if not several years so far, without requiring more therapy for the myeloma having coming back, and that's awesome. Again, we need longer follow-up. I want to see randomized studies to show that this is the correct approach for these patients and not transplant or something different. One of the limitations I will say, a lot of these patients had not gotten prior daratumumab. So that's another question. If someone hasn't gotten Darzalex or daratumumab or isatuximab or Sarclisa, which are the monoclonal antibodies targeting CD38, I'm still more inclined to reach for them right now over CAR T therapy. CAR T therapy is a much bigger deal, much more intensive, much more expensive, and obviously right now, not approved yet in the second line of therapy. That may change in a couple of years, but if it does change, it'll be as a result of these kinds of exciting studies being presented at Tandem, so I'm glad that I was here.